All right. Well, I see a handful of folks trickling in from the waiting room. We'll give it another, I don't know, 30 seconds or a minute or so until we have a quorum. I see a lot of familiar names, so thanks everyone for calling in. A handful of you have been here for all of our sessions, I think. So thanks so much for being part of what we're trying to do. Feel free to, send us some feedback, things you'd like to see next year. This year we sort of tried a new thing, and that was putting all of the Pancreas Academy talks in the span of 1 month. In previous years, it was, I think, every other week or once a month. So feel free to send us back some feedback and let us know how this went for you. Well, without further ado, I'll start by kicking us off. Welcome everyone to the CAPER Pancreas Academy webinar series. Today is going to be about the diagnosis and management of EPI in pancreatitis and outside of pancreatitis. And I'm so glad to have Luis Lara and Yasmin Hernandez-Barco here with us today. Both are very accomplished researchers and clinicians in the space. We're going to start out with a talk by Luis Lara, and he'll be talking about EPI outside of pancreatitis. Just
Right.
a brief word of introduction for you, Luis, if I may. Luis was my clinic mentor and my research mentor for a number of years while he was at Ohio State. And he is a strong advocate of education and training, and has done so many things for my career and taught me so much about EPI. So I'm honored to have him here today talking about a challenging topic of EPI outside of pancreatitis. So, Luis, you can take it away.
Thank you so much, Mitch, Dr. Ramsey. I really appreciate this opportunity and to also be here with Dr. Hernandez-Barco. And it's an interesting topic, actually, something we don't think that much about. So I appreciate you picking this. Exocrine pancreatic insufficiency outside of the pancreas. Again, Luis Lara, University of Cincinnati. And these are my disclaimers, disclosures.
Oh,
And we're good.
and sorry to
Yes.
interrupt you. I don't see your slides yet.
Oh, sorry about that. Let me see. How about now?
Yes, perfect.
Okay, thank you. So these are my disclaimers again, disclosures, and I'm going to review pancreas physiology with some etiologies of exocrine pancreatic insufficiency of that are really not pancreatic, I guess, a diagnostic approach, and I heard Dr. Hernandez-Barco was going to talk a little bit more about diagnostic tools, so I won't spend too much time discussing that, and then some conclusions. But we are going to review pancreas physiology because I think this by itself just explains a lot of how in the world can you get quote unquote pancreatic insufficiency when your pancreas seems to be working or seems to be doing okay. So we, some of our colleagues who are listening right now are probably eating, so this is quite timely. So you have food, and the moment you see food, as you remember, right, you actually start producing saliva and salivary amylase, and you start already priming your stomach for that food that's on its way, right? So actually, as it turns out, even with the salivary amylase, we already start the process of digestion in the stomach, obviously through different neural and hormonal pathways, we start producing acid and other enzymes and enzymatic processes that start breaking down the food, plus the normal function of the stomach that crushes the food until it becomes the tiny amount of food bolus that makes it through the pylorus. The pylorus, despite a lot of gastrointestinal issues, unless it's something surgical, usually works really well and only allows for a very small squirt of about zero point 0.1 to maybe 0.5 cc's of food to make its way from the stomach into the small intestine. And it does that for a very important reason that we're going to discuss in a couple of slides. But it is to make certain that the amount of food that goes into the small and the proximal small bowel is small to maximize the mixing of that food with bile and with pancreas juice. So, and then ultimately that food goes into the small intestine where a lot of the digestion and absorption will occur in the proximal small intestine for a lot of the foods and nutrients. Of course, they get absorbed throughout the whole small bowel. But a lot of this really occurs in the proximal small intestine. and the pancreas is highly important for appropriate digestion, ultimately to enhance absorption and for numerous other metabolic processes. And if your pancreas is not working well, you will suffer from maldigestion, malabsorption, ultimately, malnutrition with numerous electrolyte anomalies, vitamin deficiencies, and other problems like hypocalcemia, osteopenia, osteoporosis, and so forth. So this is the pancreas, a slide that I used from my previous institution. And I just noticed today, this actually is pancreas divisum. So I actually painted the pancreas and put them together. But anyhow, it just shows, where the pancreas lies in relationship to the pylorus. And then as it travels through the small intestine. So it's worth reviewing that the pancreas has two incredibly important functions. It's two organs in one. It has an exocrine portion with the acini composing of over 80% of the gland. And really the function of that part of the pancreas is to produce digestive enzymes. Digestive enzymes that help us break down foods into the tiny substances that our intestine can then absorb actively and passively. So amino acids and sugars and monosaccharides, disaccharides, and obviously fats. And lipase being the most important one that I'll mention in just a little bit. Plus, it produces a trypsin inhibitor, which is a way that we have of making certain that we don't auto-digest our own pancreas. And then the endocrine part, which is extremely important because it's so necessary for glucose and fat homeostasis, only comprises like less than 5% of the whole gland, with the islets or Langerhans that have the alpha, beta, and delta cells producing glucagon, insulin, somatostatin, respectively. So, and the rest of the gland is really a bunch of connective tissue and other fibers and blood vessels and so forth that make up this gland. So going really back to physiology, and again, this is highly important to understand, again, why you can actually have quote unquote EPI with maybe a normal pancreas. Let's review this very quickly. So you have a duct, right? You have the ductal here. And the secretion from the pancreatic duct, this is the functional part of the pancreas, kind of you remember for the functional part of the liver. Well, the pancreas has kind of also has a functional component. So you have your ducts that are stimulated by neural pathways mediated mostly by acetylcholine, but also a humoral pathway mediated by secretin. And then the ducts, when stimulated, produce water and bicarbonate and other electrolytes that get secreted in pancreatic juice. And this is the vehicle to bring the digestive enzymes produced by the acinar cells. So this is very important to actually neutralize the very acidic food coming from the stomach into the proximal small intestine. And it's very important because without this, the pancreas enzymes won't work, and I'll get into that in a little bit. And then on the acinar side, there are other important aspects of this because you have a few neural pathways and a humoral pathway, which is CCK or CCK mediated. This remains somewhat controversial because in humans, it's not clear that it's directly CCK. And I think I mentioned a little bit of that in the next slide. But anyhow, the packed enzymes, right, are then secreted after this stimulation, and in the preform usually as they travel through the ducts, then into pancreas juice and then into the intestine. The other important aspect of this, to again understand why you may actually have a pancreatic insufficiency with a quote unquote normal pancreas, is we also need the help from other hormones and enzymes that are produced elsewhere that, together with the pancreas, work as a system. So you have enterocytes that produce enterokinase. Again, going back to very basic physiology, we remember the enterokinase is necessary to cleave carcinogen to trypsin, and then that trypsin is the one that actually goes ahead and activates pretty much all the enzymes that are in an inactive form. And co-lipase is really necessary to eventually work with lipase to actually exert its fat digestive properties. So, and then the other important thing to mention about this is all this occurs in the proximal small bowel. All of this has to occur proximately, and this is highly important to understand some of the disease processes that lead to potential EPI. Now, I'm going to spend a little time talking, just a couple minutes, seconds, about talking about human pancreatic lipase. It is different than lipase in other species, by the way. We have very little to none lingual lipase. Gastric lipase is produced in more quantity as we're babies to digest mother's milk, but then really a human pancreatic lipase, and this is a little cartoon of one, I think, from a guinea pig, is right here. And the human pancreatic lipase is the most important one because the vast majority of lipase reproduced as humans comes from the pancreas. By the way, there's lipase elsewhere in vascular tissue, endothelial cells, and so forth. There's also pancreatic lipase-related protein 2 that has similar characteristics and function as a human pancreatic lipase. And for whatever reason, we produce a pancreatic lipase-related protein 1 that really has no known function in humans. So what's important about this is, again, to highlight the fact that the vast majority of the lipase we produce as humans comes from the pancreas. It requires colipase to function. Its maximal efficiency is in the proximal small bowel. Actually, it's very fragile, becomes rapidly denatured. Actually, by the time it reaches the proximal jejunum, it starts disappearing. So its effect starts going away. And this is important to keep in mind as I explain some potential causes of EPI. And then, of course, trypsin itself, highly important because it's the one that activates pretty much all the other pancreatic enzymes. There's a pancreatic secretory trypsin inhibitor. And trypsin is also important because it inhibits CCK releasing factor, which I mentioned in the next slide, which is important to actually leads to secretion of the acinar cells. And the other thing to keep in mind here is that there are occasional mutations in any of these pathways, which can sometimes lead to pancreatic insufficiency outside of the typical causes of pancreatic insufficiency, which we'll review in just a couple of slides. So this is just a cartoon, again, kind of summarizing what I already mentioned. But what happens here is, and this is why it's important to understand the environment and how crucial it is to have a normal functioning small intestine, is this. So you have acid from the stomach, which when dropping into the small intestine leads to the secretin excretion. Secretin works through directly into the ductal cells to release water and bicarbonate. By the way, in high doses, secretin also stimulates the acinar cells, but it also goes through vagal, afferent, and efferent pathways mediated by acetylcholine to make the pancreas release bicarbonate and water. Now, CCK and CCK releasing factor in the small bowel, which actually gets released when there is a presence of enzymes and protein in the small intestine, leads to CCK in the circulation. And this one works through vagal, afferent, and efferent pathways to stimulate the acinar cells to start liberating the pancreatic enzymes. And then, of course, once the bicarbonate is necessary to inhibit the acid from the stomach. Otherwise, enzymes to be maximally efficient need a pH of above 5, above 6, and some say even above 7. So without that, of course, enzymes will become destroyed or won't become activated. So that's why it's so important for the ductal cells and the acinar cells to actually be working not only together, but optimally. And then you have protein and protein breakdown products that negatively inhibit CCK releasing factor, thus cutting off CCK and actually decreasing stimulation of the acinar cells. So what are the causes of pancreatic insufficiency? Well, you can summarize this in 3 very broad causes. You lose pancreatic parenchyma. You have real bad pancreatitis, pancreatic trauma. They remove part of your pancreas. Maybe it's involved by tumor. Actually, for pancreatic ductal adenocarcinoma, it's really interesting that it sometimes we understand this to be a very complex process, because you may have a small tumor, not big enough to actually cause obstruction of the pancreas duct and not big enough to actually involve a lot of the pancreatic parenchyma, yet patients may develop endocrine and exocrine insufficiency. So through different pathways, neurohormonal pathways, tumors and others may affect the inhibition of release of the pancreatic enzymes, or can affect adequate delivery of active pancreatic enzymes or pancreatic juice. You need everything to be working okay, otherwise the gland, the pancreas juice just won't have the optimal pH and adequate enzymatic concentration to actually do what it's supposed to do. So this can be because of obstruction of the pancreas duct, because you don't have adequate stimulation. Start thinking about causes that could be associated with this. You just don't produce enough enzymes, or you produce inadequate enzymes, or they become inactivated, right? Because it just or there's not enough time, and this is the asynchrony, right, for the food to mix with the juice. So just start thinking about all the potential causes. Now we're going to go over those that could be associated with, pancreas insufficiency with a quote unquote normal pancreas. And the post-SIBO pancreatic asynchrony. As already mentioned, when you eat everything I've already mentioned occurs in a very a graded and synchronized fashion. The only so much food makes it into the small bowel. But what if your pylorus is gone? Then it'll dump it into the small intestine, and it just won't mix appropriately, and enzymes won't get activated. So you can have asynchrony of the motor and secretory functions. Think about stuff like potentially gastroparesis. You have an altered enteropancreatic feedback. I already mentioned a little bit of that, but it's highly important, because without this, not only do we not activate the signaling pathways to actually make the pancreas produce its juice, but also you don't have a way to turn it off, right? And the inadequate mixing of pancreas juice with food. Your pancreas can be functioning very well and putting out an adequate amount of enzymes, and bicarbonate, but still it doesn't mix with the food because of issues with it getting there, going by too fast, or the pancreas juice having to travel a long segment until it can join the food. So all of these are potential causes of pancreatic insufficiency. So they can be divided into primary or secondary. And for the primary, you have chronic pancreatitis. That's your typical one. Pancreatic resections. This just involves issues that are associated with the pancreas itself. So we call that type 3C diabetes mellitus when it's associated with pancreas resection, neoplasia, non-alcoholic fatty pancreatic disease, cystic fibrosis, and others here that are really almost always present in childhood, like agenesis and hypoplasia and all these bizarre syndromes that you probably will never see. But you can also have deficiencies of lipase and other enzymes. Actually, some patients actually have or even develop, for unknown reasons, lipase deficiencies, or they produce an abnormal lipase. It's just not clinically functional. Pancreatic hemochromatosis. As you age, as we get older, we produce less and less pancreatic juice. And also, something I'm going to mention here, and thanks to Mitch's involvement in this study, the PATHY study, and others that have really shown us that and have confirmed that acute pancreatitis can lead to primary pancreatic insufficiency, and it can also maybe even be permanent in a small number of patients. But here, the secondary pancreatic insufficiency is what really interests us when we're talking about, diseases beyond the pancreas. Anything that affects your mucosal small bowel, right? Celiac disease, IBD, even infections that wipe out your mucosa. Enterokinase, by the way, is not at the brush border as other enzymes like lactase are. So, but still, when it's all wiped out, you may develop deficiencies, and you may not produce enterokinase. Gastrinomas, just a massive amount of acid that makes it into the small intestine that the bicarb cannot neutralize. If you have any kind of surgical anatomy, anything that alters not only how food empties, but how much empties, how long it takes to be able to mix, and so forth. So think about Billroth anatomies, vagotomies, enterokinase deficiencies, primary, secondary, bacterial overgrowth, diabetes, and anomalies of the biliary tract. And when you're really malnourished, it could be that you just don't produce enough adequate enzymes because of your protein levels being so low. So I'm going to just highlight a couple of the important ones. Cystic fibrosis. By the time you see this, in most cases, it'll be quite evident because most patients with cystic fibrosis will have pancreatic insufficiency. I already mentioned pancreatic ductal adenocarcinoma. It occurs in the when it's in the head of the pancreas. It's more common, and probably because it's also obstructing the pancreatic duct. But a substantial number of patients with pancreatic ductal adenocarcinoma have EPI, and enzymes actually may be helpful to maintain weight and prolong survival. For diabetes, the causes are probably, it's multifactorial, but there is angiopathy, lack of blood flow, neuropathy, lack of response to normal neuronal and hormonal stimulus. There's fibrosis. There's even an element of autoimmunity, and that leads to pancreatic dysfunction. It's much more common in type 1 diabetes, but it can also occur in type 2. These are usually mild to moderate, as evidenced by the fecal elastase 1 that, has its ups and downs. And I know Dr. Hernandez-Barco will mention much more about this, but it's really not that reliable. Having said that, most of these patients don't need enzyme replacement therapy. Celiac disease is a very common cause of secondary cause of EPI, and as it turns out, when you treat the celiac disease with a gluten-free diet, it usually goes away. And something that I find quite very interesting in IBD. In IBD, a substantial number of patients, up to a third of Crohn's disease, have this, much less with ulcerative colitis. And the mechanism is not understood. It's not only because of the involvement of the mucosa, but also there also appears to be autoimmunity. Like a third of these patients have autoantibodies against their islets. So it's really interesting. So why do surgeries affect pancreas function? Well, I already mentioned this, and hopefully, at this point you figure out why. Well, because it not only is this pancreas not stimulated, but the food isn't exposed to the pancreatic juice, and also there's not enough time for it to get absorbed. I mean, as it turns out, some of these surgeries are exactly done for that cause, but if you look at other surgeries as illustrated here, you can understand why some may develop EPI. It's quite common, even in esophagectomy, probably because of vagal nerve damage, gastrectomies, and small bowel surgeries with a Whipple resection, and others. A good portion of these patients will have EPI. In my practice, after I see my patients who had a Whipple resection, who have diarrhea, I almost always put them on pancreatic enzymes, and at least in my practice, it seems to be just short term. So we do different tests of pancreatic function. I'm going to jump over this because I think Dr. Hernandez-Barco is going to mention this, but we have different ways of testing this. Fat and the fecal elastase 1. I'm going to pass this. So, because my time is up, but what are the indications for you have secondary exocrine pancreatic insufficiency, which is not really dysfunction? I think you have somebody has steatorrhea, real steatorrhea, well done, test to figure out if they have steatorrhea. Patients losing weight has evidence of maldigestion, malabsorption, malnutrition, vitamin deficiencies, and so forth. You have to give them an appropriate diet. It has to have fat in it. Otherwise, what in the world give them enzymes for? And usually have to be frequent high energy meals. And in patients with pancreatic ductal adenocarcinoma, strongly recommended. So in conclusions, EPI can occur with a quote unquote normal pancreas. You have to consider EPI in appropriate patients. And again, I'll go back to cancer, anybody who's had surgeries I've already mentioned, and maybe in some patients with diabetes. Correlate symptoms with laboratory tests that we're going to discuss in the next session. And in some of these cases, enzyme replacement therapy may be helpful. And with that, I want to thank you very much.
Thanks, Dr. Lara. Super great talk. I appreciate you going through the pathophysiology to remind us all of the complexity. I think sometimes we get the sense that the enzymes are all made in the pancreas and that's all there is to it. But once you understand the complexity of the system, it's easy to see how many possible ways it could go wrong. Before we move to our next talk, I just wanted to ask you maybe one follow-up question. I think one scenario where we're thinking about maybe secondary EPI is in a post-op patient, maybe a Whipple, who comes in with some bloating, steatorrhea, and you're trying to decide, is this EPI or is this bacterial overgrowth? Can you talk a little bit about maybe some ways that you might confidently diagnose EPI in that group?
Oh, absolutely. That's a wonderful question. And I'll tell you something. Bacterial overgrowth, by the way, can be a cause of this too. The bacteria can actually affect the pancreas and the bile, pancreas, and so forth. So that's something else to keep in mind. So I think, both are easy tests to do. The way I do this, I'll usually just get a qualitative fecal fat. I know you and I had discussions about this, but I'm not a fan of the 72-hour stool test. I'm also not a huge fan of fecal elastase 1, especially in this situation, because it really hasn't been tested in this situation. Somebody who's already post Whipple has a Billroth 2 kind of reconstruction. So I'll get a fecal, but I will get a fecal fat, and I may get a fecal elastase. If both are really low, I feel comfortable about this. Tell you the truth, when the patient presents like this, I'll usually just put them on enzyme replacement therapy. I can't tell you how many patients do so much better with it almost immediately, and I will be able to stop it in a couple of months in most patients. I do think it tends to be transient. And by the way, there is data on PDAC and enzyme replacement therapy regarding their improvement, a little bit in weight, but also in nutritional status and potentially in their survival. So I think it's something. And is there a lead time bias? I don't know. And for bacterial overgrowth, I think rather than subjecting them to the test, one of the issues I have with that is I've never seen a negative test for bacterial overgrowth. I truly have never seen one. So we really are good at selecting patients, or it's just too good of a test. I don't know. So I'll hit them with an antibiotic if necessary, and proceed with this. But I think that for the enzyme replacement therapy, I think for somebody who's had a Whipple resection, it's quite justifiable. Be careful, because like IBS, and I think Dr. Hernandez-Brock will probably talk about this, how unreliable fecal elastase 1 is in IBS settings and so forth. And it's an expensive drug, so you have to be careful how you use it.
Awesome. Thank you so much. I want to ask you a follow-up question about dosing of pancreas enzymes, but I think Dr. Hernandez-Barco is going to get into that in her talk.
Wonderful.
Dr. Hernandez-Barco, just a quick word of introduction. She's a physician scientist at MGH. She works in the pancreas clinic, seeing all types of pancreatic diseases, acute, chronic pancreatitis, idiopathic pancreatitis, and her research really focuses on the immunobiology of pancreatic cancer precursor lesions like pancreas cysts, in the role of the immune system in malignant progression of pancreatic cancer. So thanks so much for being with us, and I will turn it over to you.
Thank you so much to the organizers of the event for their invitation and for your kind introduction. So today I'm going to talk about exocrine pancreatic insufficiency and really focus on how to diagnose, how to treat, and then talk a little bit about future directions. And I'm very grateful that Dr. Lara put such a nice detailed overview of the pathophysiology, because it really does help understand why EPI happens. Give me one moment. These are my disclosures. So at the end of today's talk, I want all the learners to feel that they can describe and define exocrine pancreatic insufficiency syndrome, provide an overview of the etiology and pathophysiology of EPI, describe approaches to diagnosis of EPI, outline the treatment options for EPI and how to monitor patients. And then I'll go through a case at the end that I think really illustrates how to take care of patients in clinical practice. So I won't go into this part too much because it was very well explained in the last talk, but really the pancreas has two major functions, an endocrine function and an exocrine function, which is very important for digestion. And there are many things that can go wrong in digestion, and this can be related to issues with how enzymes are secreted, whether it's from a tumor or from loss of pancreatic acinar cells, whether it's from cystic fibrosis and plugging of those ducts, whether someone has had surgery. And so when this happens, you can develop a series of symptoms, which is really defined as a reduction in the quantity and or activity of pancreatic enzymes to a level that is inadequate to achieve adequate digestion. There was a group of individuals a few years back that got together both at Pancreas Fest and an AGA joint symposium, and they proposed a new definition of EPI, what they called a mechanistic definition. And what they proposed that this definition should be is that exocrine pancreatic insufficiency is a disorder which is caused by failure of the pancreas to deliver a minimum threshold level of a specific pancreatic digestive enzyme to the intestine in concert with the nutrients or foods that are being ingested, and that can lead to some nutritional or metabolic issues. And then it's also characterized by variable deficiencies in micro and macronutrients, especially essential fats and fat-soluble vitamins, or by symptoms of maldigestion. I promise I will not be reading every slide, but I do think that this definition really is quite comprehensive and helps to create a way to think about the disease that is not just the pancreas isn't making enough enzymes, so you have steatorrhea, but it's really the patient on an individual basis is not making the enzymes in an effective or efficient way for their nutritional needs. And so the true prevalence of EPI is difficult to establish, but we have at least 200,000 patients with chronic pancreatitis, and about 15% of patients have EPI at the time of diagnosis, and up to 75% of patients with chronic pancreatitis have a risk of developing EPI over the course of their disease. These patients are at significant risk for having a heavily impaired quality of life due to issues with malnutrition, maldigestion, malabsorption, and we'll go over that in the coming slides. I have a slide here very briefly on etiology, and the most common etiology that causes exocrine pancreatic insufficiency is chronic pancreatitis. And some of the others Dr. Lara went through in his previous talk. But the one that I also want to point out, which I think he did as well, is patients that have had surgery, whether it's for cancer or another reason. Any individual that has had some kind of abdominal surgery that reconnects their digestive tract, there's usually an issue with the way they're going to be digesting their food, and that the way the enzymes are being secreted and mixing with their food. And I explain that to patients when they come to my office after they've had any kind of pancreatic surgery. And so there is quite a bit of variability of screening. The patient population that should always be screened is individuals that have chronic pancreatitis, and their standard of care really emphasizes that these individuals should be screened once a year for EPI. And I'll talk about what that screening entails. I'd also like to argue that all patients with recurrent acute pancreatitis and likely acute pancreatitis should also be screened. And those patients, it can be screened with just symptoms, symptom questions at first. And if they're all negative, then again, those patients with acute pancreatitis, you can probably wait an additional year to screen again. But in anybody that has symptoms that seem like it is EPI, I would probably do a little bit more of an evaluation. And then those patients with pancreatic resection, screening and treatment is very, very variable. It depends on the surgeons, on the practice, on the hospital setting, whether or not these patients are treated immediately after they have any type of pancreatic resection, or if there's or if individuals wait until a patient develops symptoms to diagnose and treat. And so I'll move into the diagnosis now. And as Dr. Lara alluded to, there's not one test that really allows you to make the diagnosis of exocrine pancreatic insufficiency. And I have 4 broad categories, and I do go through this with patients. And the first is screening a patient for symptoms of EPI, steatorrhea, weight loss, bloating, other maldigestive symptoms. The second category of testing is some kind of stool-based testing. The third is looking for micronutrient deficiencies, especially in individuals that have steatorrhea or weight loss. And then the fourth is in patients that are high risk for metabolic bone disease, if the clinical picture fits. So when I ask about symptoms, I've listed here some common symptoms: abdominal pain, bloating, flatulence, diarrhea, steatorrhea. But I ask patients very, very specific questions to try to really understand what their stool looks like. So I ask them, do you have a layer of oil in the toilet bowl? Does your stool look like it's very shiny or greasy? When you wipe, is it very difficult to wipe? Do you have to wet the toilet paper? Do you have to get a wipe to really make sure that you're clean after you have a bowel movement. Is it difficult to flush? And often it's those questions that elicits more of an idea that they are struggling with symptoms of steatorrhea, rather than I just say, do you have fatty stools? So I always ask patients very specific questions to try to really understand how their bowel movements are, how they've evolved over time. But symptoms alone really do have a high failure rate to diagnose exocrine pancreatic insufficiency, because as you can see here, there are so many other GI conditions that can cause a lot of these symptoms. And so, the patient population that you ask these questions in, you want to have a little bit of a higher pre-test probability when screening them for EPI. With stool-based testing, I will start with a 72-hour fecal fat. I have ordered it. I think we all have, but there are certain things to know about it. It's a very good test to measure the amount of fecal fat, and it is considered the gold standard to determine if a patient has steatorrhea. But in order to ensure that you have a reliable test, a patient needs to be on a relatively higher fat diet, at least 60 to 90 grams of fat, for about 4 to 5 days. So the 24 to 48 hours preceding the test and the 72 hours during the test. And I'll tell patients that usually means an avocado, a couple tablespoons of olive oil, and a serving of nuts will usually get you to that fat goal. And then a patient has to collect all of their stool over the course of 72 hours, and then this is measured. And as I mentioned, it is reliable in telling you how much fat is in the stool. And if it's greater than 7 grams, that's considered abnormal. But it's a very cumbersome test to do. And it's often not, in my opinion, necessary to really determine if a person has exocrine pancreatic insufficiency or not. Though I will mention that all the clinical trials on pancreatic enzymes had to use the 72-hour fecal fat to measure a decrease in the fat and stool volume. The fecal elastase test, I think we all talk about it, and I do order it quite a bit, but I know its limitations. And so a fecal elastase, it is a measure. So elastase is an enzyme that is secreted by the pancreas. It's not broken down as it goes through the intestine. So it's a pretty good surrogate of what enzymes are being secreted by the pancreas. But the test itself is measuring the concentration of elastase. And so if the stool is soft or mushy, and these are the exact words I use with patients, it may give us a false positive test, because any kind of water content in the stool can dilute it down falsely. And so a patient must give a solid stool sample that is well formed and sits in the hat that they put on the toilet bowl. And then I always confirm with them after the fact to make sure that it was really a solid sample. And in patients where they just say, there's no way I can give a solid sample, sometimes I will start pancreatic enzymes anyways. And then ask them to give a sample once their stool is a little bit more formed, because the enzymes in the pancreatic enzyme replacement therapy is porcine, and it doesn't interfere with the test. So that's also a strategy that can be considered when sending a fecal elastase. But oftentimes, if your pretest probability is incredibly high and somebody is coming in with steatorrhea, then maybe you can just treat with enzymes, and even a normal fecal elastase test would not convince you otherwise. So a bit about pancreatic function testing. So it really is important for the diagnosis and management of EPI, but there's not an optimal test that exists. There is direct pancreatic function testing and indirect pancreatic function testing. So direct pancreatic function testing is actually quite good and probably one of the better ways to detect early issues with exocrine insufficiency. It's just an endoscopy, and either secretin is given or a CCK analog is given, and the amount of bicarbonate secreted by the pancreas in the pancreatic juice is measured. And if it's low, then you suspect that there is a decrease in pancreatic function. Despite it just being an endoscopy, it's still an invasive test, and it's difficult to have a patient come in for endoscopy after endoscopy to monitor their function, and really what is that tipping point where you would start enzymes. So oftentimes we'll rely on indirect pancreatic function testing, such as the fecal elastase. There are serum tests and breath tests. The breath test is actually also quite accurate. It's not available in the United States, but it's a labeled triglyceride that is given in a meal with some water, and then serial breath tests are measured to determine the pancreatic function. So it's very important, as was discussed in the prior talk, that the differential diagnosis for patients that have exocrine pancreatic insufficiency, that a broad differential is considered before making that diagnosis, because I do get a lot of referrals for exocrine pancreatic insufficiency based on a low fecal elastase, or somebody had steatorrhea, but really they had SIBO. And so I think thinking about all the possibilities, but not misdiagnosing somebody is quite important. So once the diagnosis has been established, of course, pancreatic enzymes are an important part of therapy, and I will talk about that in a moment. But nutritional management is just as important, in my opinion. And what I mean by that is a patient's nutritional status needs to be assessed. Oftentimes, this is a condition that really causes quite maldigestive symptoms: bloating, malodorous flatulence, abdominal pain, urgency, fecal incontinence related to it. And so one of the patient's biggest questions is, what do I eat? What can I eat? How can I eat? And so if you have the benefit of working with a registered dietitian, I find that this can be very, very helpful for patients, because knowing how to manage their diet in the setting of exocrine insufficiency can really help improve their quality of life. Also, counseling patients on avoiding alcohol and tobacco if possible, because that can create further damage to the pancreas, is also important. And then also monitoring any type of micronutrient deficiencies that they may have. And so I'll talk about this on this slide, because especially in patients that have chronic pancreatitis or even recurrent acute pancreatitis, they're in a state of chronic inflammation. And there's a concept known as inflammaging, so inflammatory derived aging, which really makes patients predisposed to conditions such as decreased bone density, osteopenia, osteoporosis, not just because of vitamin D deficiency that can be related to their exocrine pancreatic insufficiency, but also because of the inflammatory cytokines related to chronic pancreatitis that can lead to rapid bone turnover. And so anybody that has, especially chronic pancreatitis with exocrine insufficiency, I will screen with a bone density test at the time that I encounter them, and then every 2 years after that. And also not just looking at a patient's BMI, because there are individuals that suffer from obesity that can have sarcopenia. So their BMI may look okay, but they've lost quite a bit of muscle mass just because of the inflammatory state that they live in. So some additional management principles specifically related to patients with EPI that also have chronic pancreatitis is, these are the vitamins that I check for, and I do it once a year, even if they're on pancreatic enzymes: the fat-soluble vitamins, vitamin A, E, D, and K, vitamin B12, folate, and then also magnesium, selenium, zinc, and iron. And then I'll also screen individuals for diabetes once a year, and I already mentioned the bone density scanning. So on this slide, I have different preparations of pancreatic enzymes that are available here in the United States. And the majority of them are what are called enteric coated. So they have a coating, they're not broken down by the acidity in the stomach. But I do want to point out too, so Viacase is a non-enteric coated enzyme. So Viacase is often selected when a patient might have pain, because the fact that it's not enteric coated actually was thought to sometimes help with the pain related to EPI from chronic pancreatitis. But these individuals need to be on some kind of acid suppression, either with an H2 blocker or a proton pump inhibitor. And then the next medication I want to draw your attention to is the very last one, called Relizorb. This is a cartridge for patients that require enteral nutrition, either from a severe pancreatitis episode or, and it's actually a cartridge that attaches to the feeding tube, and it's constantly giving lipase to patients. So where if a patient's on feeds for 14 hours, for example, it's not really quite easy to dose pancreatic enzymes, but you can have patients use the Relazorb cartridge, which gives them constant lipase and prevents any issues from exocrine insufficiency. So I'll talk now about the PERT dosing and timing. And what I have on this slide is almost word for word what I will tell my patients. Your pancreatic enzymes should treat the meal, so they don't treat you. So if you don't eat, you don't need to take them. And I put a hand here and I put my pretend fork here and I say, go choo-choo. So right at the same time, don't take it. Don't walk around and do something else. Try to take it really at the moment that you start your meal. I will sometimes ask patients, do you finish your meals in 10 minutes or longer than that? Because if they eat very, very quickly, it's probably fine that they take all their enzymes at the same time. But if they actually enjoy their meal, have a conversation, it's shown that split dosing can be a little bit more helpful. So in the beginning, middle, and end of the meal. And then we don't do weight-based dosing, but in general, I'll start at a minimum of 500 to 1,000 units per kilo per meal. And in patients with significant weight loss, I'll probably start a little bit higher. So sometimes I'll do a little calculation in my head just to make sure that I'm giving them the appropriate dose. And I do counsel patients that they can have some side effects up front, because if they already feel bad, they start this medication and now they have new symptoms, they may not want to be as compliant or see it through for a few more weeks. So there are barriers. Compliance is one of them. I completely understand it's many, many pills, many, many times throughout the day, and it's quite expensive medication to commit to, and it's not always covered by insurance. The number of pills that patients require is quite high, and sometimes in order to decrease the number of pills, the size of the pill is very high, so that can be very difficult for patients. And one of the most important things is I do tell patients that it will help the frequency of their stools and the consistency of their stools, but any improvement in other symptoms should not be expected and would just be a bit of a bonus, because I think it can be very disappointing if pain is the primary driver that someone is experiencing. They take 10 pills a day and they don't feel better. So that's a very important part for me. And so once I have a patient on treatment, I do monitor them, make sure that their weight stabilizes or they're gaining weight, that their symptoms and their stool frequency consistency is improving. And then I check on the other symptoms as well. And I never repeat a fecal elastase unless a very specific situation with necrotizing pancreatitis. But in general, I don't repeat it because the enzymes won't improve that value. So it shouldn't be used as a response marker. So if somebody fails their pancreatic enzymes, the first thing I ask, are they taking the right dose? Are they taking it at the right time? Are they on appropriate acid suppression? Do they have one of the issues that Dr. Lara talked about? Do they have altered anatomy? Do we maybe have to change the amount and timing of their meals? And is there something else? Do they have SIBO? Do I have to look for another cause for the symptoms that they're having? And so I'm just going to have one slide on future directions. As you can see from both of our talks, we really need much better reliable tests for exocrine pancreatic insufficiency, but I'll mention two here that are on the horizon. So magnetic resonance pancreatic function testing, they're actually they're a little further advanced in the pediatric world, where they've standardized what the pancreas should secrete, and they've been able to standardize that in MRIs. Secretin stimulated MRIs. And so they're using it now in studies to determine if they can correlate this with exocrine pancreatic insufficiency. And so we'll, in adults, of course it exists, but we'll need to have future studies to really determine if it's a good way to measure exocrine pancreatic insufficiency. And then there's a malabsorption blood test, which again is looking at the way that certain free fatty acid and triglyceride are broken down. And so that might also be a non-stool-based test that can be helpful. And then just a couple medications here. There's synthetic lipase that's been studied. There are some yeast-derived lipases that are studied. There's a new molecule that was formulated in a slightly different way to try to be resistant to the pH of the stomach. and the proteases of the proximal small intestine, which may be more helpful in patients that have had pancreatic surgery. And so there are quite a few trials on clinicaltrials.gov looking at different molecules and different testing. So I do think hopefully when we give this talk in a couple of years, we'll have better tests and even better, more uniform treatment. And so we have 10 minutes. I will do the case in 1 minute. But this is a young man that came to me. He's 34 years old, history of alcohol use disorder, and he was having epigastric pain for 2 years. He had endoscopic evaluations, was treated with proton pump inhibitors, had slight elevations in his liver function test, but he really never got better. And he started losing weight. So at that point, almost a year and a half into these symptoms, he had a CT scan, which showed extensive calcifications throughout the pancreas and pancreatic atrophy. And he was referred for a second opinion for diarrhea and chronic pancreatitis. And at that point, he had already been hospitalized twice with some electrolyte disturbances. So in my evaluation, he had severe pain. He had lost almost 30 pounds and was complaining of almost daily steatorrhea and frequent accidents. So I started him on pancreatic enzymes with meals and half with snacks, and then ordered some blood work. And as you can see in the right-hand tab, all of his vitamin levels, almost all of them came back at really critical levels. And his potassium was very low, so I referred him to the emergency room. He was treated for the electrolyte disturbances, and I saw him again a couple weeks later, and he actually gained nearly all of the weight he had lost, and almost all of his vitamin levels had normalized except for vitamin D, and his pain had completely resolved. The pain doesn't always get better, as I mentioned, but in him, a lot of his pain was driven by the exocrine pancreatic insufficiency. And so it just shows how important it is that in patients with a high pretest probability, we do think about this and we promptly treat to prevent any kind of complication. He unfortunately did have a hip fracture, even though he was only 34 years old, shortly after I saw him. And so, maybe earlier diagnosis would have prevented that. So in conclusion, I do encourage people to think about EPI with the new mechanistic definition that was proposed a couple years ago, the EPI syndrome. And that the prevalence of EPI might be difficult to establish, but in those patients with chronic pancreatitis, pancreatic surgery, recurrent acute pancreatitis, cystic fibrosis, et cetera, we should really be thinking about it. And that there is not just one test or one question that can make the diagnosis, but really just that symphony of all those different tools that we have to make that diagnosis, and that our overall goal should really be to improve a patient's nutritional status and quality of life as best as we can. And so thank you again for the invitation. I'm happy to take questions. I'll stop sharing my screen.
That's great. Thank you so much for that presentation. There was one question in the chat, 2 questions in the chat. Before I get to them, I just wanted to ask you and Luis, I have certainly had cases like yours where you start them on pancreas enzymes and the response is dramatic. And so that generally leads me to believe that pancreatic EPI is super treatable when you make the right diagnosis and you put them on the right dose. Can you speak to your experience if a patient doesn't have that robust response like you described? What are some of your kind of next thoughts or next steps in management?
So, a few patients actually come to mind as you ask that question, and I agree. I think pancreatic enzymes are incredibly effective at treating exocrine pancreatic insufficiency. So if a patient doesn't respond, you usually ask what else. So some of those questions that I ask. In some of the patients, of course, small intestinal bacterial overgrowth is one of the first things that I think about. And depending on the scenario, I will test and then treat, or if they're really suffering, I will sometimes just treat. I think especially in the patients that come to see me with pancreas cancer that's being treated, or they've had surgery for pancreatic cancer, the way I say to them, what I'll say to you now is, let's treat the EPI because we know you have that. And then whatever's left over, we'll treat that and figure it out. So is it that maybe they're having a bit of dumping syndrome? Is it that, just the volume of food that they're eating is not what they can tolerate anymore? And so I have a general approach, but I make it an individualized approach to each patient for the most part. I don't know if you want to add anything.
Yes, no, that's fantastic. And Mitch, actually, We also await, hopefully, your paper, right, on chronic pancreatitis, pain, and enzyme replacement therapy, which is really, really interesting because it does show that it can actually help abdominal pain, whereas, generally speaking, we've been taught it doesn't. And I agree with you. We have patients who just improving their digestion and absorption helps their pain. So absolutely. So as Dr. Hernandez-Barco mentioned a little while ago, absolutely making sure they have the appropriate dose of enzymes. I can't tell you how many patients just don't take it or take it in the morning with all their pills and forget and then eat, hours later where it's pretty useless. So I think just making sure that they're taking the medication, then increasing the dose. I actually, as you mentioned, follow these patients up very closely, if not personally by phone in a couple of weeks to make sure that we don't have to dose adjust. I mean, keep in mind the amount of enzymes you can give is actually quite substantial. We actually start off with a low dose, which for many patients, thank goodness it's enough. But some patients do require that higher dose. And then I'll also, of course, treat for SIBO. I usually, again, don't test for, just treat it. And if they get better, that probably was it, hopefully. And sorry for saying it that way. I usually don't. But anyhow, and then I will also institute other therapies, for example, PPI therapy to maybe enhance the survivability of the pancreatic enzymes. I will use Viocase, the non-enteric coated enzymes, for those patients that, just have, will potentially benefit from having the enzymatic activity more proximally in the small bowel rather than distally. So I will use that, and definitely an anti-diarrheal or an antispasmodic if necessary. So, it's a functional problem too. It's not functional like, DGBI, but still it's a functional problem. And I think utilizing those tools can actually be helpful.
Yeah, and I appreciate that you brought up, sometimes you treat the EPI, steatorrhea goes away, vitamin levels resolve, but there are still some symptoms. And often I might think about maybe some overlapping of a disorder of gut-brain interaction in that situation, kind of once you've done those other tests that you mentioned. There was another challenging question in the chat. Let's say that you see a patient who's being hospitalized with severe diarrhea, describes steatorrhea, and you're wondering, could this be pancreatic? CAT scan on one of these admissions looks good. So there's no big calcifications. It's not atrophic. What are your thoughts about fecal elastase testing, empiric trial of PERT? What do you think about these kind of cases? And Yasmin, you can go first.
So as someone who in my first year of fellowship, I would just send it all, including an elastase. And I tell that story to show that you can learn. I would not send it in this setting. I really just don't think it's a reliable test when the pretest probability is so low. And I say so low because the pancreas looks normal in this case. Of course, we can have individuals with cystic fibrosis that's not diagnosed that have somewhat normal pancreas. But in the majority of patients that have a completely normal imaging study and that are presenting with loose stools or even greasy stools, I will not send a fecal elastase in that setting. I would send the rest of the evaluation and even consider endoscopic evaluation before doing that. And then if really nothing comes of it, I don't think enzymes are harmful. There are patients that come to me on them. They don't have EPI, but they feel great. I don't tell them to stop it if it's not cost prohibitive, because I do think overall they're low risk, but the shorter answer is no, I wouldn't check it. But that's sort of my rationale for why not.
I second that. Be very careful with it. I mean, we end up evaluating and spending tens of thousands of dollars telling somebody they don't have EPI or don't have chronic pancreatitis. So in this setting, you have to be very careful, and yet it's misused. But then again, this is the problem with FE1, right? Testing. If you truly have chronic pancreatitis or pancreatic insufficiency, you're going to have loose stools. And then it's a catch-22. Then is it really helpful? Having said that, when it comes back and it's exceedingly low, in the appropriate setting, again, the appropriate clinical setting, it certainly rings a bell for me, obviously. And ideally, this should be an outpatient test, and it should be, within the appropriate, as you mentioned. And I really appreciate the little pearls you sent out there regarding how much fat to consume to actually get that amount. I usually tell people to eat 3 like fast food burgers, and that's about 100 grams of fat, which is very difficult for somebody who has these GI issues. But anyhow, so this is something I'll start using in my practice. Thanks.
Yeah, I say olive oil and nuts and avocado or cheeseburger too.
The last question that I want to answer, probably before we wrap up. There's been a couple of studies recently about using PERT to prevent maybe disease progression in chronic pancreatitis or to prevent recurrent acute pancreatitis. Would either of you be able to speak about sort of what's the current evidence for that, or is it still kind of expert opinion?
There was, and please, Dr. Lara, chime in. I remember a study from the Red Journal looking at the pediatric population. I have to confess, if my son is watching, I'm sorry, I don't follow the pediatric literature as closely as I should. But that it actually was quite helpful in preventing the number of recurrent acute pancreatitis episodes in pediatric patients and potentially preventing progression. In my adult patients that I see that have either genetic risk variants or have known hereditary mutations, whether it's cystic fibrosis, but especially like PRSS1 or CAPER or CTRC, and they're having these recurrent episodes and they don't drink and they don't smoke and they don't have a lot to offer, so to speak, I do put all the patients on pancreatic enzymes. I will even use antioxidants, just because I feel that even if it helps them prevent one episode over the course of 2 years, I've done a little bit of something. And I think the pancreatic enzymes certainly have more, a little bit more data than the antioxidants, but happy to learn if there's a better approach.
Yeah. No, you're right. Actually, obviously, that data from the pediatric literature is like, wow, what in the world? How did this happen? Right. And maybe the mechanism is just totally different. It's not muddied by drinking and smoking and hopefully other stuff, right, in kids. So who knows how much that has to do with it? But you're absolutely correct. And really, the truth of the matter is it shouldn't work, because these enzymes, the encapsulated ones at least, are liberated further down in the small intestine, beyond where they should really have an inhibitory effect or significant inhibitory effect in pancreatic enzyme output. And yet, wonder what would they work, right? That's where Viocase may have an effect. And as you know, the very old data showed that Viocase, or the non-encapsulated, was the ones that really inhibited, pancreas juice output, unlike the encapsulated ones, which, except for Viocase, all the other ones are encapsulated. So why would they work? Who knows? But I think it's really fascinating and something that definitely needs to be studied in very specific scenarios. Because keep in mind, when we do this, and by the way, when we do pancreas function testing and all these tests, they're done in the whole population, where pancreatitis has very, very succinct and different, phenotypes and presentations, that I think we just kind of forget that the disease, while the end result is the same, destruction of the pancreas, may get there in very different ways that maybe we can affect if we just study it a little bit differently.
Awesome. Those were great answers. Really great talks. I want to thank you both, Dr. Lara, Dr. Hernandez-Barco, for being with us and sharing your expertise on this sometimes challenging topic of EPI. So with that, I will wrap up, and everyone look forward to next year's Pancreas Academy webinar series, which should be around, I would guess, September, October, just like this year. So thanks again.
Thanks.
Thank you. Good night.
Thank you, Mitch. Thank you. So good seeing you. Bye-bye.
You too.
Bye. Bye, Yasmin.
Bye.